I'll introduce the panel. I'm Andrew Sharp. I'm a cardiologist from Ireland. We've got an all-star faculty today. I'm very pleased to be joined by Dr. Jose Montero Cabezas from Leiden in the Netherlands. He's going to present a case of a high-risk pulmonary embolism, a patient in shock. There's an interesting recent concept called catastrophic PE versus high-risk PE. We're about to learn the difference from Dr. Cabezas. We've also got Mario Iannacone from Turin, who's going to talk about intermediate high-risk PE and the bleeding risk associated with some therapies in pulmonary embolism. And then Dr. Marcin Kucina from Warsaw. He's going to talk to us about some data using the Penumbra system. This is a Penumbra sponsored symposium. We're very grateful for their support. And we're going to talk about pulmonary embolism throughout. So I think we're at 1:15, so I'm going to get going. These are my conflicts of interest. Okay, so how are we doing with pulmonary embolism? So whenever one looks for new things to do in medicine, I think it's always good to try and find areas where there's unmet need. And there's no question that in pulmonary embolism there's unmet need. So these are some data from Portugal. It's actually a really powerful study because they did a very good job of tracking down all patients from national coding data to try and find out what happened to them. And if you came into hospital with pulmonary embolism and shock, just have a look at those data. So from 2010 to 2018, mortality falls from 74% to 63%. 63% residual mortality. So when you look at other data sets, it'll say 20-30% risk of high-risk pulmonary embolism. But these are in expert centers, like the PERT Symposium, the PERT Consortium, or centers that have led the way. That's why they're collecting data and reporting it. This is a national study. So if you have shock, you're doing badly. Now look at those thrombolytic data down. That's the guideline-directed class 1 indicated therapy for high-risk pulmonary embolism. If you're in shock from pulmonary embolism, you should get thrombolyzed. That's what they say. So in 2014, in young people, that's the gray bar, the uppermost one in the bottom middle, about half of patients were getting thrombolysis, just half of young people. And yet it declines catastrophically down to 23%. I say catastrophically because one assumes that all of these are not getting reperfusion. And without reperfusion, if you have shock from pulmonary embolism, you're going to do badly. And then you look at the higher risk bleeding groups, the blue and the orange bars, who are the older patients. They've never really got thrombolytic. So if this is our therapy for PE causing shock, we've got a problem. We need new therapies. These are the outcomes for intermediate risk PE, and many of them do fine on anticoagulation. 85% of them will do fine. But if you look at a select group, ones who present with maybe they're a bit older, cardiorespiratory impairment, they've got tachycardia, low normal blood pressure, tachypnea, they're hypoxic, and it's not so difficult to get class 4 or class 5. This is 30-day mortality. This is terrible. We wouldn't accept this in ACS. If you've got a patient with a preserved blood pressure and an acute coronary syndrome, the mortality in the modern era should be 1 to 2% at 30 days. And here we've got an analogous condition where it's 4 to 25% in a subset who aren't in shock. Remember, this is for intermediate risk PE. And then finally, these patients end up not well. So a substantial proportion, it ranges from 20 to 50%, depending on which study you look at. They're not right at 1 year. Some of it's psychological, some of it's deconditioning, some of it's physiological. It may be dead space from the pulmonary embolism, it may be RV impairment, it may be just that they're psychologically traumatized. And there's a lot of post-traumatic stress disorder from severe PE. So we've got a lot to do in PE, and we're going to talk about one possible treatment for it. We have anticoagulation, we have systemic thrombolysis, and we have catheter interventions. And today we're going to talk about catheter thrombectomy with computer-assisted vacuum thrombectomy using the Penumbra system. The latest generation is a 16 French flash catheter, which is a catheter designed specifically for the lung to be big enough to get all the clots out, but not so big that we worry about the access site. And we have a continuous engine that provides negative 28 psi continual, almost perfect vacuum aspiration. I say almost perfect in the sense that it's maintaining almost a perfect vacuum throughout. And therefore it's able to continually suck, and it has a computer processor to make sure that we try and filter clot instead of blood. So it minimizes blood loss. So we're going to see some cases with this. There's a 12 French version and there's a 16 French version, and we'll see a little bit of both. We're going to see a high-risk case from Jose. We're going to see an intermediate high-risk case from Mario, and then we're going to hear some data. So Jose Montero, I'll call you up now. Thanks very much.
Thank you very much, Andrew. So my name is Jose Montero. I'm from Leiden University Medical Center in the Netherlands. I'm going to be presenting this interesting case. It's a 76-year-old male with type 2 diabetes who presented with a collapse at home, syncope, found unconscious by his wife at the toilet, who started chest compressions and called the ambulance. When the ambulance arrived, the patient was already conscious. The blood pressure was 85/50, heart rate was 150, and saturation of oxygen 90%. And the patient presented signs of peripheral hyperperfusion. The patient was transferred to the hospital, and at arrival, he was lethargic. Blood pressure dropped to 70/50. Heart rate was 180 per minute, and sats were 91%, under non-rebreather 15 liters. The patient, when he was being evaluated at the emergency department, presented transient pulseless activity with severe bradycardia. So the emergency department doctors started reanimation maneuvers, 1 block and 1 milligram of adrenaline. It was just enough to recover spontaneous circulation. The first labs came in, and the pH was 6.84 with a lactate of already 13. The renal function was fine, and he presented already a slightly elevated LDH and a slightly elevated liver enzymes. This is an ECG, and it was an echocardiogram performed at the bedside at the emergency department, and we can observe here severely dilated already right ventricle with a depressed function, and on the ECG, sinus tachycardia with complete right ventricular block. The patient was stable enough to perform a CT with contrast. As you can see here, the right ventricle was clearly dilated with a ratio clearly beyond 1, and the CT showed signs of bilateral pulmonary embolism affecting central branches and peripheral branches as well, with a large thrombus burden. So I give it back to you.
Okay, thanks, Jose Montero. Right, Alex. So, 76-year-old, syncope, transient CPR from the wife, but perhaps it wasn't cardiac arrest, we're not sure. Comes in with 85/50, deteriorates to 70/50, tachycardia 150, 180, PEA cardiac arrest, lactate 13, pH 6.8. How do you describe this, and what's your approach?
So this is for sure something which is the nightmare in PE treatment, because this is so-called catastrophic PE with mortality rate even more than 70%. We know some data from Penumbra about ECMO treatment in patients with pulmonary embolism, and we know that patients with even systemic thrombolysis without ECMO have more than 70% of mortality. So what is the key in this patient? I think that the key is to give this patient support, circulatory support, even before, or it is important to give it before we start with any treatment. That means we should have PERT and ECMO facilities to start with supporting circulation. And then we should think about, of course, the treatment. And it may be systemic thrombolysis, of course. It may be surgical embolectomy with all the limitation of these therapies. And according to ESC guidelines, on third place is of course transcatheter treatment. I think that the revolution in last year we have now a lot of tools, new modern tools, gives us the opportunity to highlight that this transcatheter treatment may be the most important, maybe the treatment of choice in such a cases.
Thanks, Alex. So, Marcin, why not just thrombolyze, right? If you're in a district general hospital, a community hospital, you got no choice, right? You got to thrombolyze. But you're in a tertiary centre. Jose Montero works in Leiden. It's got all functions available. Why not just thrombolyze the patient? That's what the guidelines say.
Still, it is the most promptly achievable method of treatment. May I ask you in the audience, who of us has immediate access to ECMO? So we have to keep it in mind.
Yeah. And Mario, that echo showed a very sick right ventricle. People often say, what's the value of echo? Here we see very severe impairment of the right ventricle, both radially and long axis. Does that influence your choices here? Does it start to inform you about the risks of the various therapies that we could offer this patient?
Actually, this is a good question, Andrew. Actually, the hemodynamic parameters and the lactates and the biochemical parameters are the parameters that guide me most to decide the correct procedure and how to manage this kind of patient. The echo is fundamental for the diagnosis, but not in the stratification of this. Of course, it's important, but the degree of right ventricular impairment is so high that guide me, but together with biochemical and hemodynamic parameters.
Yeah, in this case, it's pretty easy, right? Heart rate's 180, lactate's 12. So a lactate over 2 has an odds ratio of 7 for death from pulmonary embolism, 7 times the risk. So let's have a show of hands. I realize, first of all, if you do not have ECMO available, please, people who've got ECMO, don't vote. If you do not have ECMO available, who gives this patient systemic thrombolysis? And who would consider catheter intervention? And who would transfer this patient to another center to be able to have things like ECMO or cardiac surgery? Okay, now those who've got ECMO available, who goes straight for systemic thrombolysis? Who goes straight for catheter intervention? Who puts them on ECMO and then has a think? Okay, so it's funny.
Option ECMO in place,
yeah,
as a bailout. Can we vote this option? The ECMO in place, we start intervention. Who is voting for such approach?
Yeah. So there's some recent data coming out of America that shows that if you put patients on ECMO, adjunctive reperfusion is very important. That ECMO alone has a much higher mortality than those who had ECMO with a reperfusion modality, whether that be thrombectomy, catheter lysis, systemic lysis. So I think if you're going to go for ECMO in something like this, you want to reperfuse if you can. Okay, right, great. So let's go back to Jose Montero. Jose Montero, we got a really sick patient. You have all modalities available. Tell us how you approached this and what you did.
I think that the discussion was really informative because actually this is the situation we are confronting in this particular situation, in which logistics are absolutely critical, right? So we have all features of high-risk pulmonary embolism. We have hemodynamic instability, no doubt about that. We have clinical parameters of pulmonary embolism severity. We have RV dysfunction, and we have cardiac markers which are really elevated as well. But we have to categorize as well the level of hemodynamic impairment that the patient is presenting, and we go to the SCAI classification, right? At the moment that the patient is being evaluated, the patient was in a level D. Remember that the patient was reanimated shortly, he recovered circulation, allowing the team to bring the patient to the CT scan. So that moment was it, but you can agree with me that in a 25 period of time, the patient fluctuated from being in C to E, D, and as you can see now, back to E. So we follow the guidelines, right? There's no-brainer, hemodynamic instability with features of high risk. Reperfusion treatment is indicated, whatever modality you have. So we're going to discuss about that. But this patient was discussed by the local pulmonary embolism team in our center, the so-called ALERT, and the patient was randomized in a trial. It's a 76-year-old patient with high-risk pulmonary embolism. The Torpedo trial just started in the Netherlands, randomizing patients with high risk to thrombectomy or thrombolysis, and the patient was allocated to the arm of catheter-directed thrombectomy. Remember that patient, at the moment that the patient was randomized, he had some output present. So the patient was transferred to the cath lab, but during transportation, unfortunately, the patient collapsed again with PEA. So reanimation maneuvers were started. The patient recovered briefly again, some output. When the patient arrived to the cath lab, we decided immediately to put the patient on VA ECMO. The whole logistics were prepared. We were expecting this already. We have mobile ECMO cars, which can be used anywhere in the hospital, but it's always already ready in the cath lab. So echo-guided punctures of the left femoral artery and vein. We bring in the drain cannula 25 French, position in the inferior cava vein, which is very important to avoid interaction with the flush system. The time to cannulation to ECMO run was 9 minutes. We are a highly trained team, so the patient was really cannulated in a timely manner, 9 minutes after arrival, the ECMO was running. Then we puncture the right femoral artery and a vein. The artery is used always to a continuous monitor of the central pressure. And then we bring in a multipurpose rapictal 6 French to the pulmonary artery. We just make one injection. We have the CT already before. We know where the thrombus is located. We just do it to take baseline pressures and just do an injection of contrast manually in both lungs to guide us a little bit during the procedure. And then we exchange the catheter for a stiff wire, and then we brought in the lining flush system advanced up to the pulmonary artery. You can see the setup here. So we cannulate one groin just to facilitate the manipulation of the system in the other groin. And you can see as well distal perfusion cannula that we place at the end of the procedure if the patient is expected to go on ECMO to the ICU. So they have some pictures of the procedure. On the left side, you have the baseline injections. On the right side, you have the final result. So you can see a huge thrombus burden occluding both main branches. So you can see with the new flash, it's coming with a catheter called Select, which allow us to catheterize selectively all the branches. And you can see here how by steering the catheter, we are using a short sheath in the groin, 16 French, we can selectively cannulate all the main branches of the right lung in this case, allowing us to clean thrombus from all the main branches. And on the right side, you have the final result, both in the right lung and in the left lung, allowing almost full restoration of flow in the main branches with some residual peripheral thrombus and a dramatic improvement of the hemodynamics of the patient. Some procedural aspects. The total procedural time, of course, was 2 hours. Total flash time, important, from insertion to removal was 25 minutes, just very short time. The reason to stop, which is a very important topic, is the clear improvement of the arterial pressure and flow restoration in the main branches. Total blood loss, another feature, has to be taken into account, only 200 cc's. We achieve hemostasia with a figure of 8 for the vein and an angioshield for the arterial sheath, and the ECMO cannulas were fixated, and afterwards we put, as we always do, an integrated perfusion sheath on the superficial artery. This is a peak of the thrombus that we extracted, and just with an ECMO flow of 3 liters, we have some pressures here pre and post thrombectomy. We can see clearly a decrease of the right atrium pressure, but also the right ventricular pulmonary artery pressure with a drop of the mean PAP from 27 to 15, and an increase of the femoral artery of the central arterial pressure, as you can see here, despite the ECMO was running on 3 liters, which was sufficient to ensure perfusion. So post-intervention, 24 hours later, the patient remained stable, hemodynamically speaking. So we did an ECMO weaning trial, which is a protocol that we have taken into account clinics, labs, and echo as well, which was successful. The patient was ready to be decannulated. This is an echo, poor window, of course. But you can see how the right ventricle is moving more enthusiastically, although a little bit dilated still. The patient was fully decannulated at the ICU with a Manta device, angioshield, and a figure of 8. You can see here how we do it on the left side. And 4 days later, the patient was successfully extubated. So, dramatic case. Luckily, this is not an everyday case. But there's few things that we have to take into account that I think are really important when we are facing high-risk pulmonary embolism patients. First of all, if the high-risk pulmonary embolism exists on a spectrum of severity, we have the catastrophic, but we also have a little bit hypertension. Both patients high risk, but absolutely not the same patient at all. So the hemodynamic status can really fluctuate within the minute. High risk management of high risk pulmonary embolism requires a high level of awareness and institutional logistics. We always say that a guy with a catheter in a cath lab is not a PE program, and this is more an institutional program, more than just focusing on the pulmonary embolism, what we call the pulmonary embolism culture of the center. It requires a lot of training and education. Lining flash system for sure enables a rapid and effective thrombus removal, short procedural times, and a strong safety profile. So these are my take-home messages. Thank you.
Thanks, Jose Montero. Just in the interest of time, come and answer your question from here while Mario gets set up. This patient was in a randomized clinical trial. If they weren't 76-year-old, would you just have thrombolized them?
Not in my center, but I fully understand that, of course, we have to take into account what do you have in-house and how can you help this patient, right? We assume that the mortality of such a presentation is extremely high. Yeah. If you have thrombolysis, you don't have access to advanced techniques, so be it. But in my center, to be honest, the treatment would have changed if the patient was not being randomized in the trial, to be honest.
I mean, systemic lysis fails 30% of the time. 30% of the time it doesn't reperfuse, and then you've got a patient who's got lytic on board.
Absolutely. But
so it's not a perfect treatment, and the residual mortality is still high. So the jury's out, but a really amazing job. Congratulations. I'm so sorry about the time. We're going to have to move to the next presentation. So Mario, you've got a case that's slightly less catastrophic.
Yes, a little bit less. So this is a 71-year-old male with hypertension, smoker, previous medical history of prostate cancer, and a stroke without any kind of neurological deficiency. The last February, St. Valentine's Day, 2025, accidental femoral fracture. The patient underwent, in the same day, of course, orthopedic surgery with spinal anesthesia, but actually a couple hours after the surgery, he experienced a new onset of dyspnea and tachypnea and severe desaturation. So he underwent multi-slide tomography, which showed a nearly complete right pulmonary artery occlusion in both upper, intermediate, and inferior segments, as you can see from all the baseline and the sagittal view here coming. While on the left there was only some lone thrombus in the inferior lobe, not so important. Of course, he did an echocardiogram who showed a normal left ventricle, a severe right ventricle dilatation with the right to left ventricle ratio more than 1, a severe reduced TAPSI of 14, moderate tricuspid regurgitation with a pulmonary systolic pressure of 65. The parameters were not so bad. 100 of systolic blood pressure, heart rate was 120. And respiratory rate 31, but he had a severe respiratory distress with a ventilatory to perfusion ratio of 60 and 2.1 of lactates. So, actually, what would be your treatment in this kind of case? Unfractionated heparin, oral anticoagulant, thrombolysis, or intervention?
Thanks, Mario. Great setup. Just bring those options back. So let's include low molecular weight heparin as an option for number one. Let's have a show of hands. Intermediate high-risk pulmonary embolism, 71-year-old, spinal anesthesia. So very high risk if bleeding occurs within the spinal space, we may have a problem. Some significant parameters of risk. A 71-year-old should not have a blood pressure of 100. It's a narrow pulse pressure, tachycardia, respiratory rate of 31, difficult to oxygenate, lactates up a bit, troponins up, RV's impaired. So this is intermediate high risk as the blood pressure is preserved, but lots of markers of risk within that. So hands up for option one, unfractionated heparin, low molecular weight heparin. That is technically the guideline indicated therapy, right, Marcin? Hands up for number two, DOAC. Discharge, send them home? No. Okay, systemic thrombolysis. Wow. Interventional treatment? Okay, we're going to treat the patient. Fantastic.
There's no bias.
Yeah. Okay, Alex, tell us what you're thinking here.
I think that the first, these are, here we have patient with contraindication to actually even to anticoagulation, not only to systemic thrombolysis with the very high risk of bleeding. And the second important thing about this patient is that this is patient on the edge. This patient is intermediate high, but let's say it's a red-orange, lactates more than 2, meaning that this patient is very, very sick. Shock index more than 1, it's 120 tachycardia, and systolic blood pressure more or less 100. So this means that this patient needs fast revascularization, fast reperfusion therapy actually. And we have at the same time contraindications to thrombolysis for sure, but even for anticoagulation. So the only option for this patient is, of course, interventional treatment. And we have aspiration versus local thrombolysis. Of course, still we have local thrombolysis. We have to use unfractionated heparin or anticoagulation and thrombolysis. which is contraindicated. So the only option for this patient is, in my opinion, mechanical thrombectomy.
Jose Montero, just can you estimate the risk of this patient having cardiovascular collapse from the pulmonary embolism? I realize the information flashed by, but what would you quote to the patient if you just did nothing?
Well, the first thing I think we need to get rid of this traffic light system of estimating the risk of the patient, right? This is a patient for sure with a normotensive cardiogenic shock. I have no doubt about that. So we might be confused by this traffic light mentality of putting the patient on the yellow thing and thinking that we can wait and just give some anticoagulation, which is in this case completely contraindicated in my opinion. So I think the patient, I totally agree that quite high risk, so he's on the verge of having a high-risk pulmonary embolism, which I think he has, right? So this is for sure enough to take action in this case.
This is this concept of normotensive shock, where the patient's able to vasoconstrict enough to preserve their blood pressure, and then they have catastrophic collapse when they exhaust that ability to vasoconstrict. So Marcin, I still think it's important when we talk to patients to try and give them an estimate of risk. Just saying, it's all terrible, you're going to die. I think we need to be able to say, what would you quote the risk of hemodynamic collapse for this patient and cardiac arrest death?
I think it's about 25-30% of.
Probably go for that.
Yeah.
But what is important, I think, whether we will do intervention or not, high quality heparin treatment is still a top of importance as a baseline.
Mm-hmm. And this in itself has risk, right? They've had a puncture through their dura mater, and they could bleed into their spine, which could be really quite terrible. By the way, if you have any points, you're able to submit questions to the panel via the app. So if you want to submit a question, either go to the microphone, and there's some on the left side of the room as well as in the middle, or you can send them through the app if you're a bit shy. Okay, Mario, tell us what you did.
Heparin. Of course, it's a joke. Okay, thank you for all the discussion. I think you point out a lot of important information regarding this kind of patient. It's not so easy to understand. I mean, it's not really an intermediate high risk scenario, but it's something in the middle between intermediate high risk and high risk itself. As always, of course, we underwent full thrombus aspiration with from the right ventricle, right femoral access, venous access with the Latin flash, and this is the baseline right heart cath, which is standard practice for me because it helps me to understand a lot about the physiopathology of the patient that I'm in treatment and actually the effect of the treatment that I performed. And as you can see, there is a severe pulmonary systolic, diastolic and mean hypertension with the mean of 42. There is a cardiac output of 3.3 liters per minute, a cardiac index of 1.7. So this is a normotensive shock with all the hemodynamic and clinical criteria, and the EPAPI, so right ventricle of 1.5. So a nearly severe dysfunction of this paper. So of this in the right ventricle dysfunction. We went for aspiration, of course. We did not use heparin. We did not administer the heparin to the patient. We just used heparin with saline to flush the catheter. And in my opinion, according also to the clinical history, probably this is a sort of normotensive shock in patient with previous probably pulmonary hypertension from other causes. We went to the intervention on the right side on both intermediate, low and hyper lobe. This is an intermediate results, and then we achieved also a good result on the upper lobe, and on the right you can see a nearly total resolution of the proximal thrombi with some nearly distal embolization. The right heart cath improved a lot. Now the mean pulmonary artery pressure is 33, the cardiac output is 4, the cardiac index is 2.1, and the PAPI score increased to 1.7. And we decided to place also a CAVT filter at the end of the procedure in order to avoid as much as possible the heparin administration to these patients. Also, the parameters, the clinical parameters improved a lot. So the heart rate decreased, the blood pressure increased, the respiratory and the ventilatory to perfusion index were much better. The in-hospital outcomes were uneventful. The patient stayed just one night in ICU, 24 hours started NOAC, and then after 3 days, the internal medicine, after admission in the internal medicine department, he was discharged. So these are my take-home messages. Risk stratifying PE is in presence of active comorbidities can be difficult. Acute and chronic PE, pulmonary hypertension, is common, especially in older patients, but yet frequently underdiagnosed scenario. Intraprocedural outcomes need careful interpretation in such cases, as PA pressure may not always reduce or normalize. Cardiac index is really helpful to demonstrate improvement and to really understand the clinical condition of these patients. Thrombus aspiration is indicated for patient instability, particularly where lysis or anticoagulation cannot be administered. Thank you.
Thanks, Mario. Just come and take your seat, and Martin, if you get your slides ready, we'll just ask Mario a question or two. So just for Mario, just for people who are in the audience, how are you using cardiac index? Is it an absolute thing? So is there a cutoff that they need to learn for normal versus abnormal?
Actually, as everybody knows, a cutoff of 2.1 liter per meter square is the cutoff of cardiogenic shock. So in my practice, I use this cutoff to understand if the patient is at risk of shock or is in a normotensive shock scenario. Once the patient has more than 2.1, according to my experience, I feel quite safe.
A bit more comfortable. And Jose Montero, you made the statement, you were quite clear you felt this patient was in shock and it was invasively demonstrated. So we noticed there was some clot left behind there, and so people's eyes may have focused on that. How much clot do you need to get out?
So you need to get as much as you need to help the right ventricle to get some air, right? So this is, we said this is not a beauty contest, right? So the objective of the therapy is not to remove all the clot, to just remove, sometimes just removing a little bit, you see immediately an improvement in the hemodynamics, right? So we should not be focused more on cleaning out all the thrombus, but more in just focus on hemodynamics when you're dealing with this kind of patients.
Yeah, I mean, in the trials that got these devices approved in the United States, we're talking about 15 to 25% clot burden reduction on repeat CT.
So it's really, really difficult to estimate when you are on the cath lab, right?
Exactly.
So I mean, you have to keep it within a reasonable margin of safety as well, taking into account blood loss and the duration of the procedure as well, right?
Yeah.
So.
We may come back to that at the end. Right, let's see, right, these are two cases. We're going to pick good cases. You know, can we consistently achieve good results in pulmonary embolism patients from devices like these? So Marcin, take it away.
Thank you very much, Andrew. Thank you for the organizer for inviting me and give me opportunity to present data from very important STRIKE-PE trial. This is my conflict of interest. I hope it will not interfere with objective message. And my topic is to present the results of intermediate results of STRIKE-PE trial, which is single-arm prospective trial assessing the efficacy and safety of mechanical thrombectomy in acute pulmonary embolism. The steering committee is chaired from Los Angeles and Dublin by John Moriarty and Andrew Sharp. The studies which are participating, it's about 80 sites on worldwide. The target population is more than 1,050 patients with acute, intermediate, or high-risk PE. The primary endpoint is safety endpoint is composite major adverse event at 2 days, and the primary performance endpoint is RV to LV ratio change also after 48 hours. Of course, we have some secondary endpoints related to the long-term quality of life and functional outcome at three months. This is the interim analysis of the STRIKE-PE trial, covering 450 patients, mainly with intermediate high-risk PE, but also with 10% of high-risk PE patients. You see the age, sex, and comorbidities which are consistent with the real-life population of patients with pulmonary embolism. Going to results, you see that thrombectomy time is 30 minutes as a median, and the all procedure time is 1 hour
and almost half of population does not require stay in ICU after the transcatheter intervention. The improvement is visible on the table. So you see here immediate reduction of systolic pulmonary arterial pressure, about 10 millimeters of mercury, which equals 90%, and it is highly statistically significant. Also, the primary efficacy endpoint is also very striking, I would say, improvement. And looking at the baseline value of RV to LV ratio, you see that we are dealing with very sick population of patients with intermediate high risk PE. In terms of safety, the number of major adverse events is very, very low. And the major bleeding are the most important and more frequent, but still is below 2%. Also, all-cause mortality is very low. The mortality in the 1 month after the intervention is about 1%. So taking into account the severity of the population we are dealing with, is I think, a great achievement of all STRIKE-P investigators. Here you see more long-term data. On the left panel, you see functional class before intervention, which corresponds to basic status of the patients. In the middle, you see the status on discharge, and the last bar is status at 3 months. And you see that after this kind of intervention, patients return to the baseline status, and also you see on the right panel that 6-minute walking distance is improving significantly. So, summarizing this part of my presentation, you see this intervention with this kind of device is effective and relatively achievable with relatively short procedure time, and also providing the improvement in the long-term observation. In the second part of my presentation, I would like to share also interim analysis of the group of patients treated with Penumbra 16 flash device. You have seen already bigger size of the catheter and more sophisticated computer algorithm of suction, aiming more efficacy and less blood loss. And again, the population of this subgroup is very similar to the entire STRIKE-P population, mainly patients with intermediate high, mean age 61, a little bit more males than females, and also typical list of comorbidities here. Thrombectomy time with the lighting flash is a little bit lower, so we may work faster, but the whole procedure is very similar. Also, the efficacy on the table is very similar. The reduction 12 millimeters of mercury, 23% of the baseline values. Primary efficacy endpoint, reduction of LV to RV ratio, very similar to the entire STRIKE-P population. And also here you see the Borg scale at discharge. It means that almost all patients left the hospital virtually without the dyspnea at exercise, with what confirms very good efficacy of this procedure. And also the safety is still on the very good level, very low number of major adverse events. It's also probably learning curve of the centers comparing to the entire population of the STRIKE-P. Also the low number of mortality and needing for the blood transfusion. And in expressway, we came to the final conclusion about this particular device, Penumbra 16 French lightning flash. Improvement on the table, improvement on 48 hours, very good results on dyspnea at the discharge, short device time, and very low composite major adverse events. Thank you very much.
Thanks so much, and fantastic presentation. So just to clarify, the the first part of Strike PE was the 12 French device, and then latterly the 16 French device has been rolled into the trial.
In fact, the first part presentation is composed.
It's both.
It's composed, yes.
Yeah. Okay, great. There's a question here that's come through about blood loss. Is there data quoted on blood loss from Strike?
You know, the blood loss, the blood loss during mechanical thrombectomy is some kind of inherited feature of this method. So we cannot avoid this, and of course we are taking care that it should be at lowest as possible. But still, there are some patients with the drop of hemoglobin level more than 2, and drop more than 2 in hemoglobin is major bleeding according to ISTL. But I think this is not comparable because the bleeding is more complex situation, because you have source of bleeding, you have some disease, we have to fight. This is blood loss, sometimes significant, but probably it is not the same. So as you have seen, the need for transfusion is still at the very, very low level.
Yeah, it's around 300 mils, I think, on average, about 300 mils on average in the trial. So next question for you, Alex, is a procedural one. So there's a device called a separator, which we used a lot with the 12 French version to unclog the catheter. It's like an angioplasty wire with a little ball on the end. Are you using that a lot? Are you using it with the 16 French? What do you think?
Both of presented cases was with Flash 16 French, new 16 French device, which is introduced now in Europe, and this device actually doesn't need any separator because the diameter is big enough to aspirate even big clots, even with continuous aspiration, the clots which are in diameter bigger than the diameter of the catheter. So no, with Flash, no separators, and of course with Lightning 12, sometimes in maybe 20-30% of cases we use separators still because it's helpful in some cases.
Okay, and that comes as part of the equipment, right? So, Jose Montero, there's a question about anticoagulation. How do you handle anticoagulation? So you've got a patient who's intermediate high risk. You want to try them on a heparin regimen. Are you using unfractionated heparin? Are you using low molecular heparin? And then how do you handle either of those when you take them to the lab for thrombectomy?
So what we do is a bolus of unfractionated heparin, but it's important here to have a framework, right? So you need to define with your team in which moment are you going to reevaluate the patient to check whether the predetermined markers you're going to use to consider that the therapy has been successful or been achieved or not, right? This is very critical. Also, the new documents have been published are recognizing this structure in order to detect improvement, lack of improvement, of worsening, and from there you need to make a plan, right? So in intermediate high risk, I believe that they say 12 to 24 hours, right? So my experience, especially if you are treating with intermediate high risk patients on the verge of becoming high risk, it's very handy to have a cutoff around 6 hours to 12 hours to make a decision whether the patient is responding or not to therapy.
Great. And Mario? So one of the big questions about this is who to pick. So if somebody's starting a thrombectomy program, who should they start with? Should they start with Jose Montero's Superman case, or should they be looking for different sort of cases at the beginning?
This is a tough question. I can tell you how I started, and how I started is like Montero cases. I started with Montero cases because I think that are the patients that may benefit the most, and are the patients that even if they go wrong, you have done everything it was possible to save that life. First. Second, are the cases that for the team are the most satisfactory, and then give a sort of and you recognize the team, all the team recognize all the partners. As Jose said, this is not a guy with a catheter, is a team, is a culture. So everybody understands the importance of this maneuver and of this treatment. And treating high risk patient in the beginning is much more difficult. Of course, it's very high risk, but it is the most appropriate and gives more satisfaction for all the team, in my opinion.
Yeah. So what I would say is, try and start on intermediate high-risk patients, do 5 or 6 cases to get the workflow and the team used to it. Inevitably, as soon as you start doing cases, people are going to throw high risk at you. But it is much harder to learn this procedure when patients are very sick. There's a question here. Yeah,
I'm going to break the rule and ask the question
yeah,
directly
go on, Greg.
So a lot of cases we face where actually the patient in the ICU, he has been diagnosed with a pulmonary embolism, yet he has not been started on heparin even.
Yeah.
And the reason is, for example, spinal surgery.
Yeah.
Or for example, they're worried because he had 1 week back a GI bleed.
Yeah.
So the question is, or the dilemma that I usually face is, they are worried in the ICU to give 4,000, 3,000 of heparin while I'm going to do the procedure to maintain my ACTs high. Surprisingly today, for example, in your case, you were giving a very minimal amount of heparin. So if you can guide me, what is your protocol in terms of if you have somebody who is very high risk of bleeding, that even the ICU people are worried about heparin, how do you manage him in the cath lab so that your tools or your kits does not get clotted?
We've got 30 seconds left, so I want 10-word answers. Marcin, you go first.
I think the situation when you are dealing with intervention in venous circumstances, it's not so necessary to have such a huge amount of heparin. I think 1,000, 2,000 heparin per hour, it will be enough.
So keep it low. You don't necessarily need it. If your catheter is continually moving and it's continually aspirating, the risk of catheter thrombosis is very low during these procedures. We're out of time. We're going to get moved out. I'd just like to summarize and say pulmonary embolism kills hundreds of thousands of patients around the world every year. The mortality ranges from 4% up to 70%. Here we've got a technology. It's observational data. There's clearly selection bias to any patients recruited, but we've got a 1% 30-day mortality. Randomized trials are coming. Randomized trials change practice fundamentally. But there's unmet need out there. There are patients who are not able to be treated with conventional medical therapies, and that's why thrombectomy is started as it is. Those trials are coming. The data are accumulating. Get yourselves trained. Get involved, because I guarantee you there are patients in your hospital who need your help. Thanks very much.
Great.